Respiratory systolic ejection murmur. What kind of murmur are you hearing? Is it functional or pathologic?
Functional.
It's functional. Why is it functional? Yeah, the kid is fine, and the words that are describing it sound happy. Yeah. What kind of murmur is that? Hear it. Yes. It's systolic. It's also a systolic stills murmur. A baby had first-line treatment for SVT in a baby. They are stable. Hold them upside down. What are you doing? What is that?
Both stopping.
We're holding them upside down. Vagal maneuvers. Yes, we're vagal maneuvering a baby, correct. And then your second one is smother the baby. What is that actually doing? Diving reflex, great. And then that does not work. Your third line, call for help. And after the help is on the way, you're doing adenosine, correct. And then if none of those are working or you can't get access, synchronized cardioversion. Okay, yes, so as a reminder, you guys got it. The order of event is not hold the baby upside down, smother the baby, like they're vagals and diving reflex. But you guys got it, it's great. Really good. What is your underlying cause of a neonate, most likely, who has a complete congenital heart block? Remember for electricity, the atrium and the ventricles aren't talking at all. Why is that happening in a brand new neonate? Yeah, mom. Why? What happened with mom?
And autoantibodies.
Her antibodies from what? Lupus. Yes, lupus, and then Sjogren's syndrome. So, yep. So we see that. Good job. Okay, we're back to some of our plumbing today. Oh no, that's not where we want to be. Oh dear. Okay, I think we're there. Okay, so for the hands, first the thumb was what? Truncus arteriosus, correct. When we have two fingers, transposition of the great vessels, 3. Tricuspid atresia, 4. Tetralogy of Fallot, 5. Yes, total anomalous pulmonary venous return. And then our sad little hand. And then thank you, let's see here, for adding the E for Epstein's anomaly, the little sign language E. So those are all your cyanotic hand lesions, and we'll talk about those. Okay, so we said if you have to guess for all the congenital cardiac issues, every single one of them, the 25% is going to be what? From last time. If you have to guess, the most common. VSD, correct. So your most common one is your VSD of all of those lesions. But was that acyanotic or cyanotic? Correct, it was acyanotic. So now, if you're watching this, we're like, oh wait, we're in our cyanotic ones. So if they've already determined that you have a congenital cardiac baby, and now they're cyanotic, your most common one is tetralogy of Fallot. So that's how that umbrella works. Okay, you can think about this. You can muscle your way through this. I think when we did the lab last semester, we talked about this. You can muscle your way through memorizing these 4, or you can understand what happens with the embryology. Way back when the baby is forming, they're kind of this 2D baby, and they roll together, and the organ becomes a 3D organ that comes together. This coming together is the septum. Okay, so right here. What happens embryologically with tetralogy of Fallot is that septum goes anterior. That anterior septum moves everything forward. Right? What does that become then? This interim right here. The septum didn't close. So if you have a septum that's not closed, what is that? That's a VSD, correct. Here's now your VSD. So it starts with that septum moving forward. So first thing that's happening is that VSD, because the septum moved forward. Okay? When it goes forward, it pulls the big blood vessel with it. What's that big anterior blood vessel? Your aorta, correct. So now you have this big giant overriding aorta because it got pulled forward with your anterior septum. If that's taking up so much room, then what's way back here and teeny tiny? Yeah, your pulmonary. All your pulmonary vasculature. So teeny tiny. And it's pissed off because it's so teeny tiny that it has to stenose down. And so if it's stenosed down and those pressures are higher, that right ventricle becomes hypertrophied. Okay? So it's all from the embryology of the septum going forward. So those are the four components, but really that anterior septum made the VSD. The VSD, because it pulled the aorta with it, it's overriding, means the teeny tiny pulmonary stenosis and pulmonary vasculature is in the back, pushing pressure on that right side. So those are those four components and the why. What of that then, from last semester, is your rate limiting step of all of those four issues? Not the overriding, the other one. Where's your rate limiting step of where you get oxygenated? The pulmonary stenosis. So depending on the severity of your pulmonary stenosis, that's just what it's looking like. The degree, however much pulmonary stenosis you have, is what is going to determine how severe this tetralogy is. If you have a lot of pulmonary stenosis, doesn't allow a lot of blood flow through, you kind of have more trouble with oxygenation than if you have less pulmonary stenosis, doesn't take as much pressure, your right ventricle is not as effective. So what's happening with those TET spells? Well, you're not getting enough oxygen because of this pulmonary stenosis into the lungs to oxygenate the body, and so they end up with sudden bouts of the cyanosis. That makes them, when you're cyanotic, you become restless and really fussy, so that's where you see some of that. And then they will end up squatting down, just like the picture of the little girl, to see if they can take some of that pressure off of the heart and be able to push all of your blood forward to overcome that pulmonary stenosis. You end up then with an upper sternal border murmur that you're hearing right at that pulmonary vasculature. Any of these cyanotic lesions, this is kind of just general rules of thumb, but any of the cyanotic lesions, you're going to see polycythemia. If you can't oxygenate what you have well, you're going to make more boxcars to try to get more blood to have the potential to have oxygen on it. So all of the cyanotic lesions and all of the cyanotic kids are going to be polycythemic. Your catchphrase, the things that you're going to look for, kind of buzzwords for pants for this would be the boot-shaped heart, a little Kibler boot, and then because of that pulmonary stenosis and that back pressure to the right heart, you end up on EKG seeing that right ventricular hypertrophy and that right axis deviation. So as with any of these cyanotic lesions, PGE or prostaglandin props. So we're going to prop open that to make sure that they are not, or they have some mixing as they're born, and then a surgical repair will take place. In general, kind of a good rule of thumb for all of these, if a parent asks, well, how long do I need to be on bacterial endocarditis prophylaxis post-surgery for a child? The answer, if it's a definitive treatment, is going to be about 6 months. 6 months. If there is still defects, it is a staged procedure, then they will continue on, but about 6 months is there. And if you successfully repair these, which many of them are, they really functionally lead very normal lives. So these have a very, very good outcome. Who's one of the most famous people that you know, and everyone's heard about, that had tetralogy as a child? Was it an Olympian snowboarder?
Shaun White.
Yeah, Shaun White, right? So if you're thinking, oh my God, he had tetralogy, yeah, completely corrected and world's greatest snowboarder. So that's a good example of some of the outcomes that you have with tetralogy. So not always, but that's a really good example of the prognosis of tetralogy. Weird Kibler boot, Kibler-shaped elf boot. Right side it hurts. Transposition of your great vessels. So way back to embryology, and I'm not going to test you on that. What happens is the two blood vessels come down together, and then right at the end, they make a turn. And so what's happening is in tetralogy, transposition, they don't get that signal. So the signals are coming down, and instead of getting that last minute turn, they just go straight down. So now you have your aorta to the right side, and you have your pulmonary vasculature off to the left side. So you have to have mixing in order to be compatible with life. So you have to keep that, the ductus arteriosus open. So they are going to be an absolute necessity for that. Or if they have an ASD, a VSD, a PFO, anything, all the better until we can get a definitive treatment for that. So it's all purple everywhere because you see total mixing for these kids. The way that you will see this and the way I have seen this tested over and over and over is that the child is in the delivery room and they don't get color. So their first APGAR score, they get a 0 out of 2 for their color. Then at the 5-minute mark, they get a 0 out of 2. At the 10-minute mark, they get a 0 out of 2, and they continue to be cyanotic. They don't ever get pink. So that's when, if you see that, they're going for transposition. That's what they're looking for. What they will start to do very quickly after that is have respiratory distress because they are hypoxic. They started at that 60% from mom, 60% SpO2, what they had in the placenta, and it just continues. So that's what you see with these kids. For the chest x-ray and the buzzwords that you would see on pants, it would be an egg on a string. In real life, unless you have somebody who had a VSD and an ASD and it was not repaired for several years, you wouldn't see that. That's a longer term finding, but that's the buzzword to know for pants. So you've got to give them PGE to keep that shunt open. They got to have surgery. Most of the time, these will get picked up on prenatal if they're getting prenatal care. So watch for a test question for pants type style that would say, mother never had any prenatal care. They're trying to say this would have gotten picked up if mom had had care, but she didn't. So if they see that and they Doppler the heart, a lot of times these children then are born at a tertiary center where there is cardiovascular surgery to be able to do some sort of staging repair right away. So if you know that, don't sit on that baby, send them out to a tertiary center. Variable but poor progress. It's what if they didn't flip or twist in utero, it's really hard to flip them. So prognosis for transposition certainly not as good as your tetralogy. Weird egg on a string. Kibler boot is your tetralogy of below. Boot-shaped heart, egg on a string, your transposition. Tricuspid atresia, go with me for this one. Okay, so the other name for it you will sometimes hear is hypoplastic right heart. So when you're looking at that, when you're talking about the right heart, what they mean is your right ventricle. So what is happening in this one, your 3 valves, your tricuspid valves, do not form correctly and they don't have normal function. It does not allow blood flow to go from the right atrium down into that right ventricle. We've said it several times. What happens when you don't have flow? No flow, no grow. So in this case, you have a right ventricle that didn't grow correctly. However, after something goes from the right atrium to the right ventricle, what's next?
Pulmonary?
Yeah, the pulmonary vasculature. So the pulmonary vasculature is still coming out of this teeny tiny little right ventricle that didn't form correctly. So this child's body has to figure out, how do I get blood that's returning from my right atrium to that pulmonary vasculature without being able to go down to the right ventricle? So it has to take the long way around. It's like having a room in your house where you're like, it's right there, but I can't get to it. So this child's blood has to go from the right atrium over to the left atrium. You're like, wait, it's not supposed to do that. I know, there's mixing. So it mixes, it goes over right atrium, left atrium, down to the left ventricle, back over to the teeny tiny right ventricle to catch the pulmonary vasculature, to go get oxygenated, to come back to the left, to come down, and then out to the body. So it's a really complicated path of how it goes, and it's all because those tricuspid valves did not form correctly. So it ends up looking like a ton of mixing because everything gets mixed twice. You have this kind of big circular pattern to get back to that right ventricle to get oxygenated. Does that make sense or is that confusing? Or both? Okay. So that's the biggest thing. You gotta have something that allows it to go from the right atrium over to that left atrium. Come all the way around to catch the pulmonary artery. On your treatment, you gotta keep your PDA open, so you have to use PGE. And then again, a stage surgery will correct this over time to be able to make it a much more unified circulation pattern. Don't worry about the different stage procedures. I'm not going to ask you about those. It's just to know it's cardiovascular surgery that will do several stage procedures. Okay, truncus arteriosus. This is one trunk, so while these two are coming down, it will turn correctly, but there's no septum between them. So it's just one large trunk that's coming off both of your ventricles. So the single arterial trunk. It usually has a VSD, which is good because that means there's mixing, so you're not as worried about these babies right at birth. And you have that mixing that's coming from both of them because of that VSD. So none of the septum formed, which means you got a whole lot of mixing there. Sometimes it can be beneficial depending on the size of the VSD. So if you don't have one that's large enough, it can be helpful. The thing about this one is you would think to yourself, oh, this doesn't sound that bad. Prognosis is probably pretty good, right? And it's actually not, because this is a really difficult surgery to make a septum where there is none. You can make a septum, but it doesn't grow with the child, so you end up having to go back and doing revision after revision after revision, and the prognosis of that is pretty poor over time. So truncus doesn't have that great of a good prognosis compared to some of the other ones. TAPVR, oh, my favorite one. I love TAPVR. It's so interesting to me. So the physiology of what is happening with this. So you have your 4 pulmonary veins, right? And these guys form, you have your 4, and they look for these particular growth signals that are put out by the left atrium. So the left atrium sends these little signals out, and they say, hey, come over here, and the 4 pulmonary veins go, and then they go hook onto the left atrium. What happens when the left atrium doesn't put out those signals? Well, now you have 4 pulmonary veins that are just wandering around looking for a place to attach. And they attach where they think they should and where they can. So they might attach to your right atrium. They might attach to a ventricle. They might attach to your liver or vena cava. Wherever they're going to try to attach, they will. The problem with that, if they attach somewhere like this, the vena cava or into the liver, now you've just obstructed everything and you're over-circulating a liver. And so it's an obstructed TAPVR. The nice thing about this one, though, is that surgically, you can move those little guys, reattach them up to the left atrium. They do really, really well. So prognosis of this one is actually wonderful. So super interesting physiology and pathophysiology and a good prognosis makes it a really interesting case. So TAPVR, really, really interesting. You gotta have that ASD though, because the ASD allows mixing. When you have these really random circulating pulmonary veins, that ASD helps be compatible with life for them. Little pulmonary veins wandering around. If they're obstructed, sorry, these are some of where the differences are. If they're obstructed, you end up with an overcirculation and pulmonary edema because it's putting it, there's nowhere to go, right? If the pulmonary veins are attaching to the liver, then they gotta wait so they can go back to the heart, and so it's waiting by backing up into the lungs and causing pulmonary edema. That's where you see that. Prognosis again, very, very good. Hypoplastic left heart, one of your worst prognoses. This one is a really sad but interesting prognosis to me. So this one is almost the exact opposite of your tricuspid atresia that didn't form. In this one, you have the left side that does not form correctly. And so functionally, you don't have a left ventricle. Well, what's coming out of your left ventricle?
Pulmonary.
Yeah, oxygenated flow with your aorta. So you're like, well, that's kind of a problem. And you're like, yeah, it is. And so there's really no way to fix that ventricle, make it grow, make it do anything. And so what they end up doing, it's a really, really interesting documentary on it, but it's a staged procedure where they end up sacrificing the left side of the heart. So you get rid of the left side of the heart, they don't take it out, but you functionally have a circuit where you don't end up needing the left side of the heart, and you end up connecting your pulmonary artery directly to your aorta, and then you disconnect and have your superior and inferior vena cava go directly to your lungs. So you have passive blood flow directly into your lungs that gets oxygenated, goes to the right side of the heart that is now the left side of the heart, that it connects to your aorta and then allows you to oxygenate. So it takes several stages, several years to get to that end stage, and there's a lot of complications that happen with that. So most common that it's causing death in the first month because they don't have a way to systemically circulate their blood, because they don't have a left ventricle. PGE, you definitely need that. And then the repair, they end up with a lot of pulmonary blood flow because it's just passively coming from your vena cava directly into those lungs. It also means that your right ventricle is in charge of circulating blood to your entire body. Well, that's fine, except that your right ventricle doesn't have the infrastructure to be able to handle those pressures from the body. So the right ventricle very quickly gets stretched out and becomes a dilated cardiomyopathy. So these kids end up on the heart transplant list relatively soon compared to all of the rest of them, because the right ventricle was never made to take those pressures. Hypoplastic left heart. Teeny, tiny little left ventricle becomes your problem. Oh, Epstein's anomaly. Okay, I'm going to tell you guys, just let me be vulnerable for a minute. Epstein's anomaly is one of my also favorites, but the way I remember it is from a very weird thing. So, have you ever gone to the gym? Probably some of you like the gym, right? You've gone to the gym and you've seen dudes that only do upper body, and you're like, dude, when's the last time you did leg day? Right? That's what Epstein's anomaly is for the heart. And that's how I remember it. I can feel my face flushing from that. So what happens is, again, that problem with that tricuspid valves. The valves themselves are displaced, and you get a lot of atrialization. So functionally, your whole right side is one giant, kind of non-functional atrium with a teeny tiny left ventricle. So it looks like this giant boxy person at the gym who hasn't done legs in a long time. Big right atrium, teeny tiny little right ventricle. So Epstein's is the heart that skips leg day. That's how I remember that. I don't know why that works for me, so if you're like, that sounds stupid, we'll look at a picture. So that tricuspid valve too low, and it leaks, so you have a lot of tricuspid regurg. Because of this, also, you end up, it's atrialized, and that's where then a lot of the SA node and a lot of your electrical panel runs through. So all of your electricity is messed up with that as well. So you end up with a right bundle branch block because that right side is affected as well. So that right-sided pressure is going to be higher. Again, teeny tiny ventricle, a really weird atrium there. So your right pressures are there. It doesn't come up with much. It's the least common of all of our congenital heart defects. But the reason that we emphasize it so much is an easy testable topic because it goes with lithium. You're like, what is the underlying cause of an Epstein's anomaly? Maternal lithium. And so it's an easy one to test people on. So if you see mom has refractory bipolar, so you're already thinking, ooh, refractory bipolar, meaning she's tried a whole lot of other things, it hasn't worked, so she's on lithium. So if you're thinking to yourself, well, let's just switch her to something else, you're like, you don't get onto lithium because something else worked. You got onto lithium because that's the end of the line for things that we're going to try. So the risk of a patient who is not stable on medication is higher than the risk of Epstein's anomaly. So we leave moms who are on lithium and get pregnant on the lithium and take the chance that they're going to get an Epstein's. But that's what to watch out for. If you say, mom comes in and she has a history of bipolar and she is on lithium, what is the baby's risk for? They're trying to ask for what congenital cardiac issue is this baby going to have, and it's Epstein's. So that's what I'm looking at. So you see the gigantic right atrium and the teeny tiny little right ventricle? To me, that's all I see is like somebody at the gym who hasn't done leg day in like a year. Okay, so Epstein is the heart that didn't do leg day. Friends don't let friends skip leg day. That is the moral of that story. For this, your buzzword besides your lithium exposure is going to be the box-shaped heart. So that should help try to remember kind of the boxing-looking dude at the gym. Box-shaped heart goes with this as well. And again, because it's that right atrium involved where all of your electric channel is, you end up with a right bundle branch block associated with this. Box-shaped heart. So what was your boot-shaped heart? Tetralogy. What was your egg on a string heart? Transposition. Yep. You're the weekend, huh? And then this one is going to be your box-shaped heart. Your right bundle branch block associated with this. I'm not going to ask you to read an EKG on this exam, but if I throw a right bundle branch block on there, that's what I'm going. So in general, so the takeaway, because that's a quick overview on all of those cyanotic heart diseases. So in general, if they're blue, so if I give you there's cyanotic, there's respiratory distress, they're not pinking up, any of your blue babies need PGE to prop open that ductus arteriosus. Anything that is going to have that back pressure is going to cause pulmonary edema. Anything that has pulmonary hypertension is eventually going to require medical and potentially surgical intervention because it's backing up to that right side. They're not getting oxygenated. And then just in general, so if you have patients and the parents are asking you, if we can, we try to wait till their brains are a little bit formed. So this is when we go back to the pediatric magic number of 2. If we can wait till they're 2 to fix the acyanotic lesions, we'll try. Sometimes we can, sometimes we can't. But we'll try to wait till they're around 2, give their brains a little bit. And then the cyanotic ones typically take a lot of different procedures, and it's a stage-wise approach. So multiple different surgeries for those. Those limiting factors that would need sooner things, if they have pulmonary hypertension, you got to address that. If they're in heart failure, you got to address that. And then are they getting endocarditis because some of the valves are an issue. Those are kind of 3 things in general, kind of takeaways from in general cyanotic and acyanotic approaches. And that takes us to the acquired side of the house. I think the next one, if you guys aren't feeling like we have to see this again, then come see me, because this should be, at this point of the semester and senior semester, you should be starting to think, I've seen this, I know this, I don't want to hear this again. That's right where we want you, because that means you've seen it enough times and had enough repetition. So you should see rheumatic fever and be like, oh, mother, we have to see this again, right? So tell me what you know about rheumatic heart disease and rheumatic fever. Whoa, group A strep, yep. What criteria? The Jones criteria, which is? Carditis, your nose, subcutaneous nodules, erythema marginatum, yep, symptoms, and
arthritis?
Yeah, the arthritis. Okay. So yeah, you guys got it. Group A, beta hemolytic strep. So it's another one in general. That's a good takeaway though, of just like lupus and Sjogren's made those antibodies that attacked cardiac muscle. There are a lot of things that mix up an antibody for cardiac. So that'll go into our next lecture. But this is another one. You're like group A strep antibody for the heart. How did that get mixed up? Those receptors look a lot similar to a lot of things. So your group A antibodies going and attacking those hearts and valves in childhood. So we see this a lot in those childhood, which is why we make the modified Centaur criteria. Why they get an extra point, because we'd rather treat more than treat less for that. ASO titers are going to tell you, was there a past strep infection? So one of the ones we look at. And then again, yep, you guys got the Jones criteria. So I think you guys, did we hit those? Carditis, any type of carditis. So you could have a pericarditis, you could have a myocarditis, all the different carditises. Polyarthritis. So think about that. If you're like, oh yeah, polyarthritis, you're like, no. It's not normal for an 8-year-old to come in with arthritis, right? So that should make you be like, huh? That's not normal. You guys got synonyms, marginatum, and the nodules. Perfect. The ones that are a little bit harder to catch are those minor ones. So how many for your diagnosis did you need of the major on its own? 2. How many if you're including the minor?
1 major, 2 minor.
1 and 2 minor, perfect. So those ones are a little bit debatable, right? Because if you have a myocarditis from whatever, could you also see fever and ESR and stuff changes? So this is one that we focus on the major criteria. Again, major criteria. Just making sure you know what that means, you know how it's described. If you guys got rheumatic fever at this point, when you start seeing it where you're like, man, we have heard this in every class, I'm so sick of hearing that, that should tell you it's going to be on your pants, right? That's how we know they weight things differently for us, and so this is one you're gonna have a question on your pants. There's some of those nodes, just trying to look at some of the things that are affecting you, okay? Your antibiotics that you're using, your penicillins, typically we're using benzathine, remember that's butt penicillin, benzathine, butt penicillin. You can use some amoxicillin if you're going to do that as well. This would be a different type of, the first time I've ever said it. We use aspirin in this kid. So the first time we've been like, wait, we don't use aspirin in children. Well, we do for 2 things. We're going to talk about them both today. One of them is going to be if it's rheumatic fever. This would be one of the times that you would pick aspirin. That's one of the things that we're going to do. And then steroids for the severe carditis. And then a lot of different therapies, particularly depending on what major criteria they have. The reason that getting this diagnosis is so crucial, let's say you have a 3-year-old that you're like, I'm diagnosing you, I got it. Rheumatic fever, rheumatic heart disease, done. You have just told this family that they're doing a lifetime of prophylaxis, right? Every month they gotta go and get a butt penicillin shot forever, right? So that's why getting this diagnosis is really one that we do as a team. So infectious disease is on board, cardiology is on board, big team approach, because long-term treatment is forever. Pericarditis. Do you think most of these for kids are viral or bacterial? Viral. What virus? Yes. What's the virus of that? No. What's the virus of that? Hand to mouth. Coxsackie. Remember, Coxsackie affects the sac of the heart, right? Coxsackie affects the sac of the heart in addition to that. So most of the time viral. If it's bacterial, it's going to be your staph and your strep. So we understand that. And it's part of the criteria for rheumatic fever. Got it. It's also things that we see when you start having an increase in autoimmune type pains. So if you have a child who's getting recurrent pericarditis, always in the back of my head I'm thinking, why are you getting this? Are you getting this? Because most kids just get hand, foot, mouth. Do you have lupus? Do you have RA? What's going on with you? So it's not meaning that equals that. It's just one of those things I tuck away way back in there. Your other much less likely things that you sometimes see, drug-induced or metabolic. So it depends for these kids, how quickly does the fluid develop, right? Children do so well if it happens over time. So if you have a super small effusion or a large effusion that very slowly over time accumulated, kids will adapt. Kids will adapt and overcome, right? If this rapid accumulation happens, that's when they start to go into cardiac compromise because they just really cannot handle that rapid response to that. So the symptoms are very similar to your adults. So if you're thinking, let's go away from those. So how does this patient present? Pericarditis, what do they look like? Do they want to be upright? Do they want to be back? They want to be leaning forward. Okay, so they want to stay upright. So if you have a kid that does, I'm like, they don't want to lay down. They want to lean forward. Okay. What do you hear on exam? Kind of crunchy. What's the thing that you'll see? What are the words that you will see as your buzzwords? Friction rub. Yep. The other way I've seen it, and I don't even know what this means, but I always see it as like practice questions. It sounds like wet leather. And I was like, wet leather? But I've seen that over time. So just if you see that and you're like, what in the world? Pericarditis. Okay. The same things that you will see, you can see the tamponade, if it's super quickly accumulation, and then fever, tachycardia. They don't feel good. But the big ones are they're leaning forward, short of breath, which is not normal for kids, and then the friction rub that you're starting to see. So those big ones that I want you to focus on for that. If you get an echo, certainly you're going to see that there's going to be fluid in that pericardial space. So you'll see a pericardial effusion. Make sense? Makes sense then if you got a chest x-ray, if there's that extra fluid there, that the heart is going to be large. It's going to look like a cardiomyopathy or cardiomegaly on exam. But if you compared that to an old one, it wouldn't be there. So it would be a kind of acute finding that you would see. On EKG, the things that we would see would be the diffuse ST elevation. So that would be the time if you're like, I think this kid's having a heart attack. You're like, no, they're not. Diffuse ST elevation, pericarditis. The buzzword for this is the electrical alternans. The way I think about that is there's a lot of fluid in the heart, so if it's swinging back and forth, you're like, it's a little QRS complex. It's a big QRS complex. It's a little QRS complex. It's a big QRS complex, depending on where it's sitting in the chest and how that's being perceived by the machine, the electricity. Certainly, ASO titers, if you think it's bacterial, a lot of the times a viral titer will say, yep, this is Coxsackie. Sometimes it's helpful, sometimes it's not. A lot of people, you'll see this, they'll get cardiac enzymes, and like, what are you doing with the troponin with this kid? You think it's, so you can get them. You're not going to do anything with them. They won't change your management, but you can get them. That's that electrical alternans that you're seeing. So you're seeing a smaller voltage, large voltage, smaller voltage, large voltage. So you're seeing as that heart is kind of swinging inside that electrical alternans. If it's quickly and they have a lot of hemodynamic compromise, gotta get that fluid off. So pericardiocentesis. If you take fluid from someone, just public service announcement, if you take fluid off of something, send it to the lab for something. Culture it, viral test it, do something. If you're taking that fluid off of wherever, so particularly if you're taking fluid off of a child's heart, send that for some testing. For this one, here's the difference. So you guys learned that for adults, how do you treat pericarditis? Colchicine or an NSAID and colchicine. I think I said that twice. For children, no colchicine. That's second or third line. If they have refractory pericarditis, so all they need for these kids are your scheduled NSAIDs. So big difference between how you're treating children and how you're treating adults. Kids is just your NSAIDs. Certainly if it is bacterial, you'll manage that appropriately. Good prognosis for both of these kids, unless they're really young, which makes sense. If you're getting pericarditis as a teeny tiny baby, those are the ones that make me think, ooh, something not normal here. We need to watch this kid, autoimmune, early stuff going on. So poor prognosis there. And then if it's recurrent. If their body continues to make the recurrent accumulation, just an overall poor prognosis. Okay, hypertension. There we go. I like hypertension. Oh, this is the new one. Yes. Okay. So, how many of you guys for Peds Lab Day saw a child that was between birth and under 3? How many of you successfully got a blood pressure on said child? 0 out of everybody, right? So that's some of the takeaways. It's really hard to get a blood pressure on a child because number one, Their pressures are pretty low. Number 2, they are like octopi, octopuses. I don't know the plural form of the octopus. Octopi?
Yep.
Wow, that was an embarrassing moment.
You got it right the first time.
Octopi. And it's one of those unnecessary for the most part that we don't need to get. So we typically, as a rule, and the American Academy of Pediatrics says, we don't standardly get blood pressures on children at well visits until the age of 3. So at 3 is when we're going to start getting that at all the well visits. So before that, let the octopi run wild. The selective screening, the ones that we will say, nope, you still got to get this. If you were premature, if you have already known congenital heart disease, which the most common of that is the VSD, your most common cyanotic congenital heart disease, tetralogy, perfect, yes. And then the big one, renal disease. If something's wrong with your kidneys, you aren't going to be able to handle your pressures and your angiotensin system appropriately, so I need to get a blood pressure on them. The rest of those should make sense. You had cancer, if you had other things that are associated with hypertension, your neurocutaneous disorders, so neurofibromatosis and tuberous sclerosis. So right back to the prematurity, the reason that we do that specifically for them is if they had a central line placed in the NICU, their chances of having stenosis are much higher. So if they had a UVC, a PICC line, some other central vessel manipulation, so prematurity, the caveat, prematurity with central line manipulation in the NICU, outside of the realm, but I have to say. Okay, so good luck with the next one. So the ideal way to get the blood pressure, please have the child sit in a calm, quiet position for 5 minutes prior to taking your blood pressure. Super good luck to you all doing that. Sometimes you get a kid that will kind of just calm down a little bit before you get blood pressures, and their heart rate really calms down and their pressures very quickly, so that's okay. And then appropriate cuff size. So that's the other thing that we also often see. Just in general, if you're thinking, I know I don't need to memorize vitals, that's fine, but like what's what? So a quick version would be, what's too high would be 100 plus their age. So if you have a 5-year-old, anything above 105, I'm like, can we check that again? And then the low would be 70 plus 2 times their age. So for a 5-year-old, I would expect them between a systolic pressure between 80 and 105. So when those quick checks, if a tech is bringing me stuff and I'm just looking at it really quickly, if it's in that normal range, great. Right? And I already know that's the normal range. We'll talk about what to do when it's not the normal range. Same as the adults, you need 3 elevated readings. And this is another population that really does have white coat hypertension, right? This scares them. They're not scared of this, especially in the military. They see this all the time. Their parent wears this. They're totally good with normal just clothes. You put a white coat on, nah. So that was always the thing that they would tell us in medical school, don't show up to your peds rotation in a white coat. So we're gonna coat you guys because we're gonna have a white coat ceremony. We're not letting the Army take this from us. We're having a white coat ceremony. Don't wear it to your peds rotation. Okay? Love it, not to peds. 2 types of the hypertension. So very rare that you see a primary or essential hypertension in a child. Certainly if you're an obese or very, very unhealthy adolescent, sure. But if you think about that, blood pressure, because of the vessels, is an old person disease. When you lose that elasticity inside your vessels, it's like you have a hair tie and you've lost the elasticity. Kids don't have that. Very, very compliant vessels. So most of the time, not a primary hypertension. Your secondary hypertension, or where it's at. They're younger, they're higher, and most of the time, it's from their kidneys. Okay? Big difference. Then, you are going to look like you don't know what you're talking about if you send a child with hypertension to the cardiologist. Because the cardiologist is going to say, their blood vessels are just fine, what do you want me to do with them? So where do you send pediatric hypertension? Nephrology. Again, just because I have to, not urology. Not urology. Nephrology. is where they're going to go. The most common cause is that renal disease in these kids. They go to nephrology, not cardiology. The nice thing, they changed this a couple years ago. And so what you need to think about is, are they a teenager or not? So teenagers will fall into the adult criteria of 120 over 80. It was a big change for all of us. All of us were like, oh my gosh, this is so different. It's so much easier now. So if you are a teenager, got to stay under 120 over 80. If you are less than that, it's by percentiles. And I'll show you how to calculate these. But again, 3 different occasions, under 13. And then we have a couple of things. So blood pressure, I said this way back in block 1. Is blood pressure a function of your weight or your height? Height. Why?
This is the brain.
Can it get to your brain, right? So while I think about their weight, if they're overweight, I actually don't care about that. I care about how tall they are to determine what's normal for this kid. So I care about their sex, their height, and their age. Because those 3 things are going to tell me what's appropriate or not. Then I got to do, based on those charts, based on their sex, their height, and their age, are they below the 90th percentile? Because that's normal. Are they between the 90th and the 95th percentile? Because that's elevated, but not hypertension yet. Are they 95th percentile for their age, plus 12? That's stage 1. Plus 12 like millimeters of mercury as you're taking those. And then are they greater than that 95 plus 12? That's stage 2. Will make sense. The rest of over 13 again is your adult norms. Okay, so this is the chart. You will have to have this. I will have to give you this chart. You do not memorize this. You will have this in phase 2. I will give you this chart. So this is the things that you're looking at. I'm looking to say it's male or female. I'm looking to see the age and their height. So when we're looking at this, I see that this is the age, and I've already said that this is a male chart. So their age, their percentile of height, and then male. Okay? So if I'm looking, let's say a 3-year-old, the 3-year-olds, I take their height and it's 50%. So the 50th percentile for a 3-year-old says that they should have a blood pressure less than 107, less than that 95th percentile, or less than the 90th percentile would be up here at 103. Okay, so 107, it's got to be less than that to be not concerning. So if I get up to the 95th percentile, then plus 12 is 119. So between 107, 119 is your stage 1. Your above 119 is going to be your stage 2. We will go over this again after the break because I see you guys have departed. So we'll try again in like 11 minutes. More. You got this, okay? So let's go over this again because I know this is really, this can be hard. So we said it's a boy. So we've determined which chart we're looking at. We said we got to know how tall they are because blood pressure is a function of height. And then we said, how old are they? So a 3-year-old comes in. They are the 50th percentile of height. They should be at 103 or less. That should be normal, okay? When you get between 103 and 107, that's where that elevated hypertension or elevated blood pressure, not hypertension. 107 to 119 is then stage 1. Beyond 119, stage 2. That makes sense then? How you read that chart? You gotta ping 3 times. You gotta get age, height, and then find your column down to do that. So I will give you a chart if I need you. Again, do not memorize these. You gotta make sure, is it looking at the boy chart, girl chart, percentile, and follow it down. Okay, so if it's above the 90th percentile, so anything below 90, we said that's normal. Good, we got it. Anything below 90, we're good. If it's above 90, pick this answer always on the test. Take it again. It's something you can repeat. You're not repeating a blood draw. You're not repeating a procedure. So retake the blood pressure with a manual cuff. If it's too big, too small, you're going to get those abnormal amounts. Okay? If you've done it 3 times, you've said, yep, I've done a manual cuff, the cuff is the right size, we've done it 3 times, this actually is high blood pressure and elevated. First thing, if it's elevated, you're going to give them their education, so their lifestyle, so what kind of diet do we do? The DASH diet, what does that actually mean? We're like, do the DASH diet, and they're like, what can't I eat? What is the DASH diet limit? Sodium. Yeah, so same for kids, and same for especially older kids. So making sure that they're not having a ton of processed foods, that they're eating real foods, all of that kind of stuff. And we repeat it in 6 months. If they're in stage 1, so we've said they're between the 95th and the 99th plus 12, you repeat it just in a couple weeks. We want close interval at that point to make sure that it's actually that in addition to your education piece. If it's stage 2, I need to pick up the phone and call nephrology because they need to get in within a week or 2. I think this is some sort of renal disease or some sort of autoimmune disease that we're missing. So within a week is when they need to be seen for a true stage 2. So this is meaning it's a true one, you right cuff multiple times, it's consistently above 95th percentile plus 12. Things when I think, ooh, this really is bad. So I think about that if the child is a normal BMI. So if the child totally normal sized with height, normal sized BMI, and they're in a stage 2 hypertension, I think to myself that's more than likely a secondary cause, more than likely renal. The other thing is if you just see flat out above 140 over 100, that doesn't matter how old you are, that's never normal. So if you're consistently getting that, don't care if you're 13, if you're 5, that's going to be an indication that there's more likely a secondary cause. So what are those secondary causes? So we've said potentially things that you see. So coarctation of the aorta, again, what's that going to look like? What are your upper extremity pressures? Lower? Low? Yep, you see that again with Turner syndrome, which there's an S, I need to take that S off. That is Turner syndrome. So bad on me, that's the old one, Turner syndrome. Any kind of renal disease. So your cafe-au-lait macules, what else are you looking for with cafe-au-lait macules? What are those other things for your diagnostic criteria for NF1? What was your homework? Freckling, you had some axillary freckling. What was the inheritance pattern? Autosomal dominant, yep. So if a first degree relative had NF1, that would be another one that you would see. What happened in the eyes? What did you see in the eyes?
The retinal.
I know you know it, you're saying it. The spots, the Lish nodules, seeing those, yep. Your precocious puberty, you might be seeing that. So how old would that be? If you're a female, under the age of 8. If you're a male, 9. Good. Renal disease again, if you have a pheo, because a pheo can be an answer to anything, and then exogenous steroids, or this would be another cause. What's your workup then? What would be expected at your level if you end up with one of those elevated after 6 months or a first degree hypertension? For your first one, you're going to try to get that 24-hour ambulatory blood pressure monitor. If you're getting some studies, the things that I would consider. I want a UA. What is the UA going to show me? What are you looking for in the UA?
Low GFR.
Spec graph, what are you going to see would change the spec graph? Protein. I want to see if there's protein. Yep, so UA is going to see if there's protein or not. Your BMP is going to say, do I have normal kidney function or not? And then a kidney ultrasound. We see are there polycystic kidneys? Is there renal artery stenosis? What's going on with those kidneys? Other things that I would get to or think about, you're in pediatrics, so when in doubt, thyroid studies. If I say thyroid studies, what does that mean? You're actually going to order. Yep, TSH and your free T4, because those get married together. Other things, when I look at renin and aldosterone, metanephrines for your pheo, some of those other, if there's another vascular study you need to get. So really what I want you to highlight and have here is number 1. The other ones you're gonna see later on. But what I need you to know is that first screening level. Some other review here. If you're doing other CV risk factors, when did we standardly get lipids? 17 to 21 and 9 to 11, correct. So you had those 2 times. What if your parents had a cholesterol greater than 240? When did those kids get screened? It's pediatrics, so 2, correct. Yep. Other things to think about, are they diabetic? And is the secondary cause because they have an endocrinopathy? So your A1C glucose, are they obese and this is a sleep study? Is this a neoplastic issue and they need a uric acid? And then an echo would be your very last thing. So again, first thing would be your ambulatory blood pressure monitoring and some screening labs to focus on number 1. If it said stage 1, we already said that, lifestyle interventions, indications for management would be you get to truly stage 2 or stage 1 that has failed your interventions, up to that point. If they are truly a diabetic and have high blood pressure, if you have a child, think about that. If you have a child who is already diabetic and already has high blood pressure, they're in a world of hurt. Okay, so that's one that you need to make sure that their blood pressure is controlled because they're at high risk for basically everything, and every chronic disease, but much younger. Things that we would use, and this is really kind of more for the nephrologist, but so you're aware, because children's vessels are so compliant, we can use those calcium channel blockers pretty first line compared to the way we do in adults because they're so responsive to those, and their vessels are so responsive. So calcium channel blockers, or your ACE, if there's kidney issues, are going to be some of your first things that we would use. I will tell you, even as a pediatrician, I don't think that I have ever been the first person to start somebody on an antihypertensive as a child. It's the nephrologist. I will just end up refilling it if they're stable. Some of the other things, you can use any of them, but it's just not as much first line. You made it through P's, or cards. You guys would like it. If this was a junior class, you would like it still. Switch over to heme for a bit. I always debate if I should just press or if I should stop because the soul leaving gets worse. So some of the time I'm like, let's just get through some of the material so that it can end. So you guys. No, but this is no.
Whoever gets that
part the keys for primary care.
There you go. It's whoever gets
We're hanging out after this. Anyway, okay. This is a part that everyone messes up every semester, and I desperately, desperately want your class to be the first that doesn't. Okay. So there are 2 parts of the cardiovascular system. Okay. If you're in my ClinCore group, I have harped on this till I am blue in the face. The first part is the cardio part. The second part then means what? The vascular part, okay? So cardiovascular means that anything in the vessels belongs to the CV system, okay? So oftentimes, because it deals with blood, everyone, and myself included, it ends up being in the heme lecture. Right? So people always think, oh, this vessel thing is heme, or this vessel thing is rheumatologic, or this vessel thing is immunologic. The vessel is part of cardiovascular. Okay? So I need you to put vasculitis. Vasculitis is in cardiovascular. I know that sounds so elementary, but everyone misses these test questions. So I'm like, vasculitis is the CV system. My very favorite diagnosis. I told you guys I like a lot of different diagnoses throughout. I've said, oh, I love this. This is so much fun. This is great. I'm telling you, this is my favorite all-time diagnoses, and I'm gonna ask you a test question on it. For a subject-wise, it was hyperbilirubinemia. That's always my favorite one. I love bilirubin. That's my favorite subject in peds. This is my favorite singular diagnosis. It's really cool when you can help these families. It's my favorite one. It's on your pants. I'm gonna ask a question or two about it. Okay? I'm just telling you right now. Hinoch Schlottenline purpura. Okay? Which means that you have what on the skin?
Purpura.
Purpura. And purpura is coalesced together what? Petechiae. Yes. Good. Okay. So it's a vasculitis, which means it belongs to which system? Cardiovascular. Thank you. It is the most common vasculitis in children. So you will see this. And they'll always say it's kind of in the school-age children. I think the most common, and statistically, it's under the age of 6. Most kids I've seen with this are about 5, 6, 7, 8. So that's kind of the age range. Early elementary school. So if you're thinking about what age to study this, or to put it in your mind. Most of these children will also have had some URI that happens before. And so even though we don't have a great mechanism for what's happening with vasculitis, the idea of this is they had some sort of illness that was kind of innocuous, and then that antibody, that IgA antibody, goes and attacks the blood vessels. Okay? We said from other previous ones that IgA is where? Yeah, any kind of mucosal lining. So if you have that lining inside the blood vessels, that's why this is going into, it's why it's an IgA. You see that one. So this is small blood vessels. Those IgAs, they go into the small ones. They infiltrate into the tissue, so they cause a lot of edema. They cause a hemorrhage into that area. So you get that petechiae that leaks out, that then coalesces together, makes your purpura. You get some ischemia because you have that localized hemorrhage, and then you have the IgA complexes because of the vasculitis. So we'll talk about what that does, where that is going to be. So my pet peeve with the way that the diagnostic criteria is that the first thing they will say is to the features you will see of this is number 1, a rash. Like, purpura ain't a rash. Right? So you're going to hear the rash of HSP. You're like, I know better than that. It's not actually a rash, but that's what everyone calls it because you can see it on the skin and because you can feel it because it's palpable, it's raised. But it's really from that localized hemorrhage, from the damaged vessels that leaks out and coalesces together because of how much it is. So the rash is actually the palpable purpura. Inflammation of the skin, it extravasates, and the interesting part about it is that it's usually below the waist. So it's prominent on the legs, it's prominent in the calves, on the butt, but it stays usually below the waist. So if you see some, you can imagine that you would see that, and you think to yourself, I see purpura all over the legs of a child. I got 2 diagnoses so far in my tank. What are those 2 diagnoses? HSP. Neisseria. Yeah. So we had a Neisseria meningitis, right? So if you're thinking to yourself, oh Lord, does this kid have Neisseria, or do I think this is an HSP? Right? So are they sick, not sick? That's why the toxic, not toxic is super helpful to know, because that's going to help you immediately. Do I need to tap this kid and get what antibiotics? Ceftriaxone and Vanc. Do I need to get this LP and a ceftriaxone and Vanc going, or is this HSP and I have some time? Okay. So lower extremities kind of starts small and it'll start to expand. The other thing that's happening is that blood vessels go everywhere. So they are going to go into all of the different parts and into the joints. And so these kids come in mostly with arthralgia. Can be some arthritis, but we'll highlight arthralgia since most of the time. And so they hurt. And so you don't often see a 6-year-old that refuses to bear weight. The 6-year-old that says, I'm not going to walk. I'm going to just sit down or I just stand there. That's actually the most common way I've seen it is you have a 6-year-old that just won't walk into the ER. So they get brought in by their parents and they have petechiae on their lower extremity, but they don't look toxic. And you're thinking to yourself, that's got to be HSP. Then the abdominal pains. The abdominal pain is because there are vessels, a ton of mucosal vessels with that IgA inside the gut, and they're doing the same thing. So there's some extravasation there. There's some local hemorrhage and ischemia in the intestines. So if there's local ischemia and some hemorrhaging in the intestines, what lab or what thing can you do to see if that's actually happening? Fecal occult blood testing, yeah. So that should be positive then, because some of that mucosal lining is sloughing off. The fourth one, where else are there a ton of blood vessels? It filters your entire system. Your kidneys, yep. So there's, well, spleen also. That's fair. Spleen also, but this one, so there's a ton of renal involvement. So this one you can see a glomerulonephritis from those IgA deposits into that can cause some hematuria. That makes sense. We have some bleeding into our urine. High blood pressure. This can be one of the causes of high blood pressure in a child. Or then they can even go into renal failure. If they're going to go into renal failure from the glomerulonephritis, it's most of the time pretty early in the first couple of months. Makes sense then anywhere where you're going to see some of this extravasation and localized edema, you're going to see it mostly in that lower extremity. So you can see a lot of edema in the toes, in the calves, scrotal swelling, labial swelling. That should make sense. And then anywhere else where there's a secretory component to it that has that mucosal layer. So the pancreas has that, they're secreting your pancreatic enzymes. So if they have a pancreatitis, what's going to be elevated? Your lipase, correct? And then an orchitis. What other infection caused an orchitis from the secretory issues? Yeah, mumps. Great. And then rarely an encephalopathy. So other things. This might be a differential. Did you guys get to ITP yet? You guys got ITP? So this could make sense. I have another reason that I might have petechiae besides Neisseria that we've learned. Could be ITP. So, but in that case, well, you're thrombocytopenic, so you don't have platelets. So that's going to rule that out. Could be leukemia. Is this actually bruising? Because they don't have anything? Well, their CBC is normal, so that's going to rule that out. Is this abuse? Right? Well, that's a weird level of abuse. It's just the waist and below and petechiae, but something to think about. It's coalescing. And then again, your Neisseria. So if they're toxic, if they're very ill appearing. So your workup from that, we just said the CBC ruled out a lot of things. So the first thing is going to be your CBC. So the platelets should be normal or elevated. Pause here. In children, platelets are an acute phase reactant. So if you see elevated platelets in a child, their CMP or their CRP and their ESR are probably elevated too. So platelets respond when they're sick, just like anything else, because the kid's sick, and so everyone's like, are we going to bleed? Are we going to die? What do we need to do? And it elevates. So it's an acute phase reactant in children, as is the rest of them, right? So your white blood cells, ESR, and CRP are going to be high as well. Your kidney function can be bumped. So you can see that UA that might have protein, your BU and creatinine might be elevated, and then, like you said, your whole blood could be positive if you have that gut. Your diagnostic criteria then says, I gotta have 2 of the 4. And for whatever reason, this one makes me laugh, because literally one of the diagnostic criteria for HSP is you're a kid, right? Under the age of 20. So it's really funny. Let's say you have a 24-year-old with these exact same symptoms. They don't call it HSP, they call it IgA vasculitis. And I'm like, that's silly. But to have true HSP, one of your criteria is you got to be a kid. Okay? That's one. Your second one, by itself, if you have palpable purpura in that pattern, lower extremity, you're not toxic, normal CBC, you have HSP. The other 2 would be the bowel ischemia that you're seeing and that colicky, crampy abdominal pain. And then I've never seen it done with the biopsy. So if you did a biopsy, you would see those IgA deposits in the vessels. 2 out of 4. Yeah, so that's exactly it. So when they come in and you're like a kid with constipation, you're like, is this HSP? But that's one of the things we look for. If the kid comes in, they said, my tummy hurts, I'm 7 years old, and I come in and my knees hurt and my ankles hurt, and you're like, you're probably just constipated and whining, but you might have HSP. Right? So that's how you're building those differentials. Exactly. Most cases, they last a couple weeks. The body figures out, oh, I don't need to make these antibodies against IgA. I don't need to do that at all, and it will resolve completely. What the problem is sometimes those antibodies come back and they attack again, or then they come back and they wax and they wane for up to about a year that you're seeing this. Typically, if they truly do have an arthritis, the joints are preserved, so they are totally fine there. One of the things that we will see is there's so much gut inflammation and so much edema that you will sometimes see that becomes a lead point and you get that telescoping of the bowel. So you end up saying, ooh, I thought we just had this crampy abdominal pain, now I have some intussusception going on. That might be on your test to say, spell intussusception for me.
Right now.
If that happens and it is unattended to, that's where you're going to get complete infarction of the bowel because now everything is kinked. Blood vessels are kinked. Starts to create bowel perforation. And then if you have renal involvement, that's when you really say, that's how you get to know these patients. And that is why I like this so much. Number one, because parents are really freaked out. You get this weird palpable purpura that looks like your child's bleeding. They're totally freaked out. Then they won't walk. Parents are like just beside themselves, and so you can come in and you're like, I know what this diagnosis is, I can walk you through this, and then because often the renal is involved, we end up seeing them for a long time. So when I say that there's outpatient management and we're following them for their renal function, the first 4 weeks we do a UA every week, and then we do a UA and blood pressure, so blood pressure and UA every week for the first 4 weeks, and then every month for a year. So I see these kids a lot. So once they have a diagnosis of HSP, I'm like, you and I are going to get to be friends for the next year. And so it's one of those really cool diagnoses that you get to see them and help when they're really scared, and then you really walk through with the family over the next year. So it's like primary care meets urgent care meets emergent care at its finest. So great diagnosis. And the outcomes obviously are pretty good. Yeah.
Can you give the insights if they have
Yes, so that's a great question. Do you give the NSAIDs? So yes, because it's typically temporary, and the acute time frame, the benefits outweigh the risks of worsening any kind of renal function. So yes, great question. You still are going to give your NSAIDs for that. If this pain is severe, so again, you have these kids that are like, I won't even walk. I have seen these kids truly need some opioids for pain too. So depending on if they're inpatient. The prognosis is one of those ones where you're like, that's a weird sentence, and you're like, it is, because they have an excellent prognosis unless they have a really rare, really bad prognosis, and then it's really bad. And you're like, that's really what it is. So great prognosis, except for the few that do go into renal failure, and then it's a really bad prognosis. But overall, HSP, a lovely prognosis. So it's great till it's not, exactly. And nephrology. I usually send them to nephrology because their kidneys took a hit. Okay? So again, vasculitis goes with cardiovascular. These are the small vessels. So anywhere where there's a teeny tiny small vessels, meaning kidneys, skin, gut, and you're going to see that palpable purpura in a kid whose bowel hurts, or you could get a biopsy. You're doing that long-term management because of the kidneys. I'm going to ask you a couple questions on HSP. The other vasculitis is Kawasaki disease. So this is the other one, cardiovascular. There's two vasculitis I need you to know, HSP and Kawasaki's. The difference between the HSP and your Kawasaki's in terms of the vessels we're talking about is that this is your medium-sized vessels. So a little bit bigger. The classic medium-sized vessel is where? There's some in your extremities. Yes, your heart, right at right up in your coronaries. Coronaries are your like placid medium-sized vessel. So we don't know what's happening. The idea is very similar to HSP. They got sick. There's some sort of antibodies. These antibodies tend to love the heart. Think the congenital complete heart block. Think rheumatic heart disease. This is another one that's the proposed mechanism, although nobody particularly knows. Its highest frequency is in Japan, hence the name Kawasaki's. It's usually younger children, though. So younger children with bigger vessels compared to your HSV. Those are the ones you see. And the idea of why does it go, why do we think it maybe goes with these viral and URI type things? Well, because the peak times are right after cough and cold season. So some of the thought behind that. So Kawasaki's. The way that I want you to think about Kawasaki's is when you start to think to yourself, this child has 7 different diagnoses, it's probably not. Most normal, healthy, happy children will have a single unifying diagnosis. Usually there's going to be one thing that can do this. So if you start thinking to yourself, so if you're looking at this and you're like, well, they've had a high fever for 3 or more, or for 5 or more days. So high fever, typically 102, 103, 104. And you're like, well, let's see, roseola did that. Okay, so roseola just had this high fever. Okay, and then they have conjunctival erythema. I bet they have conjunctivitis. Yep, conjunctivitis and roseola, that's it. Then they have the strawberry tongue and the scarlatina-like rash. Oh, strep throat. So I bet it's roseola, strep throat, and conjunctivitis. And then cervical lymphadenopathy and hands and feet swelling. So it's probably hand, foot, mouth, conjunctivitis, strep throat, and roseola. Right? When you start thinking it's got to be 4 or 5 different things, that's when you should start thinking, that sounds like Kawasaki's. Because Kawasaki's looks like all these different viral components at the same time. That's the way to think about that. So those first couple weeks, the defining thing is they have to have fever consecutive for 5 days or more, which is where back to that fever lecture when we said the hand, is remember the hand, starts day 1, gets worse day 2, 3, kind of peaks day 3, 4, and starts to trail off. If you start growing more fingers, that's why we care. Because that is your #1 diagnostic thing that you have to have for Kawasaki's is fever for more than 5 consecutive days. Then the skin peels, platelets are super high, it's that inflammatory response, and we worry that those medium-sized vessels are involved, so your coronary arteries. That's what I most worry about. I increase risk the longer the fever, so if the fever's going 6, 7, 8, 9 days, I worry about that. If they're younger, less than a year, I worry about that. And then your convalescent phase, the thing that we're watching is that ESR to start downtipping, to show that the final stages of this inflammation that's downtipping. So the things that I'm looking for, so this is what this is trying to show you, is this child has some conjunctivitis, has some rashes, has red chapped lips, looks kind of dehydrated. See, this is, to me, this is where I'm like thinking, oh, is this hand, foot, mouth? Is this parvo? Is this conjunctivitis? Is this strep throat? And I'm thinking it's got to be all of those. That's when I start thinking it's got to be Kawasaki's. So the way that I've seen the pants test this is they give you dry, cracked lips, strawberry tongue, the eyes, and the fever. And so it's really trying to throw you off with those distractors. More peeling, more conjunctivitis, more dry, cracked lips, more strawberry tongue, more morbilliform rash. 5 days, plus those other ones that we talked about. Same thing, over and over. So my labs, the things that I want to get. Blood and urine culture, so I want to say, is this truly an infection or am I missing an infection? Can I catch anything in the blood? Can I catch anything in the urine? What are my acute phase reactants? So if my WBC is high, ESR, CRP, they're going to be elevated just like they were for HSP. So you see those elevations. And then I need an echo. I need an echo at the time of diagnosis, but if you remember back, which I know you all do, if you remember back, the acute phase was a week or 2 before you saw the aneurysms at like week 4. So do you need the echo for today?
No.
No, you don't need the echo today. You need it to be able to compare in that 4 to 8 week mark. Okay? So if I'm thinking I need the echo at diagnosis, would this be one that I would call the cardiologist in the middle of the night to come in for?
No.
No. So you call them and you consult them in the morning. You need the echo as a baseline echo. You don't need it in the middle of the night. Okay? I learned the hard way, consulting a neurologist in the middle of the night for an EEG, a rapid EEG. And I learned the hard way calling for cardiology in the middle of the night. We don't need it right now. I need it in 4 weeks. I'm like, thank you, sir. So time of diagnosis, and then a couple weeks later when they're at the highest risk for those coronary aneurysms. We hospitalize all of the kids with Kawasaki because they need IVIG and aspirin. What's the other thing we gave aspirin for today? Rheumatic heart disease. Yep, so rheumatic heart disease got aspirin and Kawasaki got aspirin. IVIG, so we want to try to get antibodies against the antibodies that are attacking their vessels, and then the high dose aspirin. The 2 things that we are giving aspirin for. What was the thing that you gave aspirin plus what equals Ray syndrome? Chickenpox, which your virus is? Yep, varicella. Good job. I think you guys are dying, so let's stop. We'll just cut it. So okay, if only if you promise me. Those 2 things went with the cardiology lecture, okay? So that means vasculitis goes with cardiovascular. Please don't miss these questions. You guys are going to be the first class. I know it.